You're listening to the Physio Matters Podcast in association with Choose Health, and this is session 1. Thanks for tuning in to what is the launch episode of the Physio Matters Podcast. I'd better introduce myself and my intentions. My name's Jack Chew. I'm a specialist MSK physio working in both the public and private sectors in adult services. This podcast intends to provide a long-awaited voice to the UK's leading names in the field of physiotherapy. As things stand, there are some powerful views being stifled by the 140-character limit on Twitter, so I shall be interviewing a whole host of experts in the industry, discussing so many topics and articles that listening is bound to improve your knowledge, clinical reasoning, practice, and your interpretation of the latest evidence in the field of physio. Today's episode features an interview with Dr. Lee Herrington, who is, amongst other burdens, the man responsible for some of the country's most famous knees through his role with the English Institute of Sport. He's also a senior lecturer at the University of Salford, and through that, Lee was able to find us a room free from freshers to chat about his work. One thing's for sure, Lee can certainly talk plenty about knees, therefore we've broken the interview down into 2 parts. Today's part 1 should hopefully whet your appetite, ready for part 2 once the suspense is appropriately built. So let's get to it. Lee, welcome to the show, and would you like to introduce yourself?
I'm Dr. Lee Herrington. I'm a senior lecturer here at the University of Salford, where I sit within the Faculty of Health and Social Care. In terms of what I do here at the university, I'm a programme leader for the MSc in Sports Injury Rehabilitation, and I'm primarily a research physiotherapist here. Apart from that, I act as a senior physiotherapist within the English Institute of Sport, where I work on a multi-sport role. Fantastic, and so a number of roles that you're balancing all the time. Without us being a bit, this is your life, where'd your career come from? What's your story in terms of history? Way back when, I suppose I was a frustrated athlete. I went to university at Loughborough University to start with and did human biology and was a frustrated athlete there, so I was the usual Loughborough wannabe. And then I went back up to Manchester, studied physio up here in Manchester, had a variety of NHS roles for 4 or 5 years, as well as sort of doing sports injury clinic work, sports teams work. Completed my master's degree in sports science of injury from MMU around about 96. And about that time I started my work with Wigan Rugby League, which continued on till 98. So I did 4 years with them. And along with that role, I was fortunate enough to work with Great Britain Rugby League and some of the other rep level sides, Yorkshire, Lancashire, and a few other bits and pieces around that. I then came out of Wigan for various reasons, including having a little boy, and you don't get much of a life, and worked for Bupa Hospitals for a while, so set up a sports injury service over on the Wirral. Took up a post here at the university in 2000 now, and did various consultancy in and around sports, second opinion work around injuries, private practice work along with my university role, and then got cornered to go back into sport in 97, where I joined Great Britain women's basketball team, which roped me back into the whole sort of Olympic sport thing again. And through that, I got gradually roped in through consultancy and then into a part-time role with English Institute of Sport. And sort of going into the games, and for the previous 3 years, I worked with British swimming as my main sport, along with having an interest stroke a lead role in knee injury rehabilitation at the same time for the Institute. That sort of got me to here, I guess.
Okay. So quite fair to say, quite a colourful career so far. In terms of where that's taken you, how have your thoughts and concepts changed, do you feel, over the years?
I suppose I was very fortunate, like a lot of people who trained way back in the sort of late 80s, early 90s, and they had a lot of very good, strong mentors about at that time, some really sort of free thinkers in physiotherapy who were very much about at the time, and I was very fortunate. There was a lot of emerging concepts in the early 90s, so Mulligan came on stream, neurodynamics, the muscle imbalance stuff came over from the States via Shirley Sharman, and obviously from Australia as well. So there was just a whole hodgepodge of sort of concepts and things around in the sort of early 90s, which was quite an exciting time to be a relatively junior physio, because you could pick up lots of philosophies. And at the time, because a lot of work was less pressured than now in the health service and things like that, you had time to develop your ideas and use stuff, throw stuff away, keep stuff. And so what you got was probably a more broader church approach to how you did things. So it wasn't uncommon that you would use some Mulligans, some muscle imbalance, some neurodynamics, all at the same time, all with the same patient, without somebody saying, "What sort of physio are you?" It was like, "Well, I'm a physio sort of physio."
Yeah. All right. And so you mentioned a few things there in terms of neurodynamics. You actually were published in those sorts of areas as well as the shoulder, even at one degree. You looking at your research, it has then tended to go towards being best known for your work around the knee. And what led to that?
I guess I was fortunate enough to have a senior role in orthopedics way quite early in my career, and so I got to deal with a lot of cold and trauma orthopedics, and most of that is lower limb. And I suppose my research on the knee will probably get to that discussion, probably develops around an interest in the lower limb rather than the knee. And so the knee was a convenient sort of conduit to develop ideas around sort of lower limb and lower limb performance. So, and if you're looking at lower limb performance and one very overt pathology, it's probably patellofemoral pain is the most obvious thing. This sort of kneecap in the middle of the body floats around and is influenced by everything around it, whether that's uphill proximal through the hip, the femur, or downhill through the tibia, the foot. They all sort of rotate or derotate about the knee. So I guess you sort of got to the point, well, the knee's in the middle, so it allows you to explore a lot of things. And that was where it started. And I suppose at that time, Jenny McConnell's thoughts were very much firming up around the patellofemoral joint. So that was quite a dynamic area in terms of the options you had as a physio and the successes in an area which orthopedics really didn't touch. It was very much owned by physio, so it was quite an interesting thing to get into. So you had a lot of emerging treatments, if you like, and an opportunity to use them because no one was really interested in the patellofemoral joint apart from physios.
Okay. And do you feel like that's then we've taken that as our baby? Orthopedics are leaving us to it now?
I think orthopedics keep trying to fight back a little bit, and probably rightly, because there are some Meccano things which can be done which can help the patellofemoral joint, especially as we're going into a degenerate patellofemoral joint, where sort of like, realignment strategies may be useful, especially when we've tried everything else. The worn out knee, and whether we microfrac or whether we reorganize and replace the articular surface is certainly an option down the line, which should be there. But there's probably a lot more fundamental stuff we can do way before we involve the sort of orthopedic guys in this. So yeah, I still think we have, and we should have, sort of ownership around those pathologies before we necessarily then refer on to our orthopedic colleagues.
Do you think it's fair to say that orthopedically there's still work in progress? It's certainly something that hasn't been fully understood. There's no gold standard yet.
Yeah, I think the big problem with patellofemoral pain, anterior knee pain, whatever we're calling it, is, well, there's multiple issues. I suppose the first one is differential diagnosis, and actually calling what the patient's problem is, because that will to a degree set your sort of starting point. Have we got a patellofemoral problem which is based around irritation of the synovial tissue or the retinaculum? Have we got a patellofemoral problem which is based around a subchondral bone issue, an osteochondral, a degenerate patellofemoral joint? Is it the fat pad? Is it the patella tendon? Is it a hybrid between the fat pad and the patella tendon? Is it the plica? There's a whole sort of load of things, and you pick any one of the above and the prognosis is different. And that's probably one of the sort of errors in reasoning we make. We probably rightly use a lot of the same treatment approaches to all the different diagnoses, but we have an expectation that they will get better in the same time frame. So they probably need a biomechanical input, they probably need a manual therapy input, they probably need a strengthening input, but the time frame over how those are going to influence the symptoms and turn the patient around so they can return to their chosen activity is probably grossly different. I guess the simplest is if we take a fat pad irritation, it will resolve very, very quickly. It's biologically very active tissue. If we offload it and we de-stress the tissue, it will respond quickly, it will stop hurting, it will stop releasing inflammatory chemicals and triggering pain responses. But that irritated fat pad could be secondary to a tibiofemoral OA, it could be secondary to a patellofemoral OA. So we give them some symptomatic relief, but we don't fix the problem. And equally, we might take a patellofemoral problem and it's retinacular, and we tape it and we get instantaneous pain relief, which is probably where the successful other research which was reported from the people down in Melbourne and Australia came from, because they had a young population which was probably mostly retinacular synovial irritation. And then possibly the work Tony Wilson et al. Have reported where they don't get quite the same success is probably because they've got an older population with a degenerate joint. And, we're in danger of throwing out taping as being hopeless in the UK and brilliant in Australia, but actually we're probably talking about different population subsets. So for a retinacular synovium, it's probably going to be a first-line treatment to relieve symptoms and get them going. For a degenerate patellofemoral joint, it's probably a adjunct to allow us to start to reload that individual on a very progressive loading problem. Totally same effect, probably same technique, i.e. relieving pain, but a totally different use of the technique in terms of the goals you want and the timescales you want in an influence.
Good, and I mean that brings us nicely on to the research that you've been involved in here at the university in anterior knee pain and patellofemoral knee pain. Tell me a little bit about where we are with that at the moment, or where it's been, maybe.
I guess we probably need to start at the beginning. We probably started with, like a lot of people, if we put it in a time zone, with the whole VMO thing. And back in the 90s, which probably is 100 years ago to a lot of the listeners, the VMO was the sort of be-all and end-all of patellofemoral treatment. And so we had this concept of the VMO being significant in pulling the patella medially. And so we looked at, the relationship between VMO and exercise, and certainly found there isn't an exercise which essentially stimulates VMO specifically without getting overly geeky, without a very good research reason for why you're finding an increase in activity. So for instance, the electrode placement over VMO, if we do an exercise using our adductors, we will get what we call crosstalk. In other words, we'll get electrical activity from our adductors, which will boost our so-called signal from our VMO. So a lot of the research which shows increased VMO in exercise is usually when we've done an adductor exercise as well, and looking at crosstalk. So we kicked around VMO for a little while and went, okay, it's probably quadriceps. And then in terms of quadriceps, we probably got into this concept of a dyskinetic quadricep, a quadricep which isn't working properly globally. So there was a couple of things with that. One was probably strength, absolutely per se, and we've done work where, regardless of how you strengthen the quadricep, the people improve. So whatever is the least painful way to strengthen them works to improve their symptoms and improve their function.
And that's very individual then, per athlete or patient.
In terms of the research, we just obviously randomise people into groups. But in terms of clinical practice, it would probably be try closed chain. If it hurts, then try open chain. Fundamentally, you've got to find a way of breaking into that quad and getting it stronger, because that will decelerate the load. It's sort of counterintuitive, I guess, but if the quad works more, you push the patella more into the trochlea. And that sounds bad, but actually it's good because it will increase the contact area. So it will spread the load across a bigger area of the patellofemoral joint, so it decreases the stress in any given area of the patella. So strong quads equal stress spreading, if you like. There's a few other things with alignment we'll probably discuss. And then in terms of the dyskinetic quad, what we also found was related to patellofemoral mechanics. Your patellofemoral joint is obviously a dynamic contact joint. So no point of the patellofemoral joint is in contact all the time through range. So let's say point X is degenerate, it's only likely to be in contact at degree Y. And what we found, and we followed up some research of previous researchers, was if you had this degenerate patellofemoral joint, what it caused was almost a local reflex arc. So what you would do is when point X contacted angle Y, you switched off your quad. So what that did was give you inhibition, and that classically we described as a brake phenomenon or pseudo-giving way. And in a patient, they're the people who go down the stairs and feel they're falling, or do the opposite, where they keep the leg in full extension and don't bend it because they're almost afraid that it will give way. They don't trust their leg on the stairs. And again, yeah, that can be a sign of significant ligament disruption. But if we haven't got that history, that I don't trust my leg on the escalator, is probably patellofemoral and this pseudo break. And then when we're looking at rehabbing those individuals, there's no real point just keeping on making them work over that painful angle because it's just going to hurt more. So again, that tailors to the individual, finding out where that break is and working around it and either side of it to try and get work into it. So I suppose that's our break phenomenon work. And then I guess we'll get on to the alignment thing, but that's probably where we perceive taping comes into the story, where it doesn't really have any big obvious effects. It might change position slightly. It might change the muscles plus or minus. It might, it definitely relieves pain.
Do you still feel like the jury's out a little bit in terms of the muscle activation influence of taping?
I think we need to pick our horses for courses. I think what we've got is we've got an ability to change with taping, and that can be positive or negative. And we did some work where we made people worse, per se. And then I suppose what you do is, how I suppose I interpret that work is, if someone has an optimal strategy and you make them suboptimal, then you're going to give them pain and inhibition, or a pseudo inhibition because they're not working normally. So if I can make someone normal abnormal, I should be able to make someone abnormal different, and that different might become normal, so we get better quadriceps activation, or it might be worse because we've loaded it more. And I think the thing people need to sort of consider with tape is probably a Brian Mulligan phrase, which is MBG or BBG. It's either no bloody good or it's bloody good. So people should put the tape on and see an immediate change in a very definite subjective or objective marker, and they shouldn't maintain the tape unless they've had that positive change.
It needs to be obvious. It needs to not be subtle.
Overt, yeah.
Okay.
No subtlety, big change in pain. You're looking at 2 to 3 on a numeric rating scale, at least. That's what the taping research sort of indicates. You're looking at can't squat, can squat, has a severely restricted, inhibited quad, can get a reasonable quad contraction. You're looking at overt changes, not maybe possibly feels a bit better.
Okay, so that's subjectively. Objectively, you would expect as good an overt response to the tape?
Again, we did a piece of work where we did it with patellofemoral patients, and we put them on an isokinetic dynamometer, and we pre and post taped them, and we got significant changes in strength. So overtly,
okay,
as it would be the expectation in terms of that sort of performance. So you're looking at that obvious change. Again, one of the patella position studies we did, where we looked at ultrasound scanning patella position, then taped, showed a change. We also monitored pain on an objective chest, a step test, and again that changed it. So you need that subjective and, if not full-on objective, certainly pseudo-objective change. So it's potentially measurable.
And it is a bit of a minefield, isn't it, in terms of pain inhibition it's not wholly a pain inhibition change, but equally that will play some part. So it's a bit of a minefield. But in terms of patella position, where are we with that at the moment, do you feel, when it comes to taping? Because it was tight, there's quite small amounts of change, wasn't there?
Yeah, I mean, we were looking at just beyond measurement error in the sort of changes we do, which is, we were talking 2-3 millimeters, which is remarkably small. But if we take, and probably one of the great things to look up from this is probably Scott Dye's tissue homeostasis hypothesis. And so essentially, to paraphrase a lot of thinking from people like Scott, is if we make a small change in the biological environment, that can be significant. And that's probably quite important to take home. What we're doing may be on the fringes of not measurable with our current technology. So just because we can't measure it doesn't mean it's not there. We just haven't got sensitive enough measures, because as clinicians we see positive benefit, so there's got to be a reason. We just can't measure it yet, is another way of looking at things. And so, looking at that change of homeostasis is quite a useful way of, describing to the individual why they get injured, but equally why we're going to make changes.
But that doesn't necessarily sit well in an orthopaedic framework, does it, in terms of something being wrong and being fixed, and therefore having a definite mechanism for that effect? And so that's sometimes... Do you still encounter a disagreement when it comes to that with surgeons?
Well, essentially we're a physiological being as well as a mechanical being, and we've got an over mechanistic approach to our pathology, which is probably from the medical model or from the orthopedic medical model, where it's got to be something's not got to be lined up. We don't consider the stresses of tissue. So we have athletes who run perfectly who still get injured. We have athletes who run, like Kermit the Frog, and they don't get injured, but they sit within their homeostatic zone. They have got enough education to perform within their biology that they don't break. Or the excellent athlete gets loaded beyond their ability because they are so good and they break. And this sort of... we need to consider the biology and the sort of physiology of what's going on, as well as the mechanism. If we look at the best studies looking at predictive factors, so whether that's alignment, strength or whatever, we still only describe maybe 25% of what's causing the effect. And you take knee valgus classically in a group of people, and you scatter plot these people, there'll be 1,000 people, say in the Greg Meyer, Tim Hewitt studies on ACL, there'll be 1,000 people, and they've found 20 who get an ACL injury who fit into that classification. Now that's great research, and I totally buy into what they're doing, but there's another 980 who have the same performance parameters but don't get injured. So it can't be just about the mechanics. There's got to be a why me, why now biology sort of explanation on top of it.
Okay, I mean, as physiotherapists, we've almost been quite attracted to a more mechanical diagnostic approach to a structural one because it keeps us in business. But do you feel like to some degree that's gone a little too far on some occasions?
I think one of the reasons perhaps we don't get people better I don't mean this in an insulting way in the long term, is that we don't look at a biological approach and we don't allow time for tissue adaptation. So if we take an osteochondral lesion in the patellofemoral joint as a classic, they've got degenerate change that can't change. Well, if we sort of look at it and we go, well, what's causing the pain? Well, it can't be the cartilage because there isn't any, or it's aneural. So possibly it's the underlying bone which is being stressed because there's no cartilage. Now, bone's incredibly biologically adaptive. So if we can get that bone happy with its stress loading, now whether we unload the bone or change the loading on the bone or take time to bring about an adaptive change within the bone, then that person will get symptomatic relief. We all know the classic stories. I've certainly had patients who come to you with grade 4 changes in every compartment who can walk barely a mile, and then if you give them enough time and you build in their training and you gradually progressively load them, at the end of it they're running across America, and I have a patient like that. And so what you've got is until you're dead your body adapts. It just takes a hell of a long time as we get older. When we're younger, it's easy. It's very biologically bouncy, and it copes. And we sort of we have this expectation because we're very good at doing pain relief. We have an expectation then you're cured. Mm-hmm. And what we do is we not address the underlying biology and the tissue stress. So we've relieved the pain, whether that's taking away the inflammatory chemicals or relieving the neural sensitization or whichever hypothesis we're going for, but the biological tissue underneath is still weak and very load intolerant. So then we need to build up the load tolerance within the tissue, and that takes time. And that, again, is a biological sort of fact. So if we've got a patient who we think's got an osteochondral problem, a joint problem, if you like, they're coming in with a classic break phenomenon. They're describing a catch of pain when they squat. Their knee effuses a little bit when they really overload it. It's stiff in the morning. It gets achy after a lot of activity, the typical OA knee descriptor. We can relieve the pain quite quickly if we tape the fat pad. We'll get rid of some of that cytokine flare. We tape the patellofemoral joint. We change the loading slightly. They feel better. But has the bone biology changed? Nah. That's 6, 12 weeks, 18 weeks down the line, and the patient needs to learn that it doesn't change quickly.
In a sporting world, and to a lesser degree, but still relevant in a musculoskeletal physiotherapy world, patients and physios are in a rush. They're in a rush to prove themselves. They're in a rush to get back to doing what they want to do. And so they buy into that pain relief as being fixed. Do you feel like as a profession we need to back ourselves more in terms of timeframes and how long we explain it's going to take?
I think we need the athlete, the patient to understand we can get them across a white line. We can do what we have to do to make them available for this weekend. But at some point we've got to pay Peter because we're robbing Paul, sort of thing. And what we need to do is we've got to get them to understand at some point they're going to have to deal with this biological problem. So you're in season, it might be a case of getting them across the white line because you just got to every Saturday. But once you get out of season, it then is taking the athlete out of that environment, saying, right, we're gonna reload your tissue. We're going to gradually build up tissue stress now. And one of probably the worst things which happens to us as physios is probably at the end of the season, the athlete perceives they need to rest. What the athlete needs to do is stop doing the high intensity activity, but they don't need to really rest. Mm-hmm. And it's sort of that, certainly post 2012, there's a lot of sort of evidence within the media, and most people can see the cases of people who've had a prolonged time off and then have struggled to get going again because they're in their second, third Olympic cycle. Their body's degenerate. They've got broken bits and they're really struggling to get to that peak again of performance because their tissue just hasn't been given the time to get going again. We took them to such a low level with all the rest they had that it's a long way back up.
Okay. And that happens not just in elite sport, but particularly the seasonal nature of sport. And
Yeah. It happens with the seasonal nature of patients. We all know we get spikes in when patients turn up. Post-Christmas is classical, Everybody stops training, everybody puts on weight over Christmas, and then after Christmas they have their New Year's resolution to get fit. Instead of gradually increasing what they do, they go like Billy-O and like bonkers at what they're doing, and they all get injured.
First good gardening weekend of the spring, maybe.
First good spring weekend, pre-season training. From doing nothing, we suddenly go and do two hours of training, and then we do it again in a couple of days, and our tissues just go, whoa, what are you doing to me?
When it comes to addressing the underlying problem, which I think as physiotherapists we kind of understand, but in sporting terms it's kind of the elephant in the room, is that you try and monitor symptoms, and it comes to the point where that needs to be dealt with. Do you feel like that's something that we do well, or do you feel like that sometimes that's hidden from? Are people scared to broach that with an athlete?
I think because everyone wants to get across the white line, we're very much in danger of sort of falling for the sort of magic tricks and the sort of card tricks and the sort of medicine men approaches, where we constantly seek a new way of making the patient feel better, rather than addressing sort of some fundamental things. They run badly, they land badly, they have poor intrinsic strength. Those are the problems. But what we do is we give them symptomatic relief, and we come up with a new hypothesis of pain relief. And it is interesting if we look at, say, CPD type activity over the last 10 years. Acupuncture, which is an incredibly useful modality, it's very popular. Taping, whether that's KT or otherwise, and a lot of the soft tissue based techniques have really come to the fore again, which, a cynical eye might say they're palliative, they're pain relieving, they're not actually dealing with the issues. And all physios would say, well, then we deal with the issue. But in reality, how many, hand on heart, actually do deal with the issue, and how many just go relief, patient goes?
It's not as trendy though, is it? And that's always going to be an issue, is that to actually get to the crux of it and have that awkward conversation with a patient or an athlete, that's not quite as... It's not going to get you a high five as they walk out of the clinic every time.
Yeah, it's why it's easier in some ways, especially when you're elite sport, that they have a diagnosis and have surgery. Because then you can rehabilitate them. Then you have a period of time where you're allowed to work on things, whereas it's a lot harder to work on things in season. We've sort of all been there. It's not meant as a criticism, it's meant as an imperative, get them fit for Saturday, or your P45's on the floor on Sunday. And we work with that imperative, but at some point for the athlete, and it's probably the athlete level we need to get the buy-in, is that if they want to have a prolonged career, if Mrs. Smith wants to keep walking around the shops, for a prolonged period of time and stay, ADL independent, they need to build the load tolerance and the strength within their biological system to cope. They need to get stronger.
If to some degree we all understand, or we all feel like doing these temporary solutions or keeping people in season is at the very least, it might stop them actually getting better if we don't improve them rehab wise. But in some studies, particularly the ones that you've been involved in, if there's certain taping techniques, for example, that might decrease the muscular activity or functional strength of, say, the quadriceps, could we be putting them at risk of injury by going too far, by doing too much in terms of pain relieving strategies?
Yeah, we got sort of the problem is with I guess our work where we've done that and we've changed things is it's contextual. It's sort of, you could look at it two ways. We looked at the use of a hip rotation brace in a recent study, which we didn't report the EMG elements, but that decreased gluteal muscle activity, for instance. And you could look at that as, if you put the brace on, the glutes activity decreases, which could be bad. Equally, you could argue it the other way, which is they've already got weak glutes. So if I decrease the demand on the glutes by wearing this brace or having this tape on, so those muscles don't need to work as hard, perhaps the patient will catch up to that level. So again, we don't want to take away clinical reasoning. You've got to do it on the patient and see what the reaction is. So I think people need to be aware that pain relief is one element, and there will be a positive or negative impact on relieving pain, because by relieving the pain they could just overload even more and stress the tissues more and cause more problems. So there's the masking effect. There's equally we switch off muscles, as you've rightly said. That could be a negative, but equally it could be a positive, because it could actually then put them at a level where they can use their muscles and then work to move up. If we take simple tasks like cutting, changing direction, we're looking at the gluteal muscles have got to recruit at about 60% of body weight in terms of strength to control that sideways movement, that frontal plane collapse. And so, if someone's weak, they're not going to get N equals 60%. And so if we give them a brace, we might allow their weak, say 40% muscles to achieve 60. So we're allowing them to then cut, which then might allow them to build the adaptive strength within their system that they then get stronger for the task. And then over time, if we wean them off the brace, we then get them in place. So I suppose the answer is yes and no to your question.
No, that's fair enough, but that's the industry, isn't it? As long as we can justify it to some degree and we have an end point in mind, would you look at certain techniques or certain modalities? I know you mentioned K-tape, for example, which you were involved in the London Olympics. It was all over everyone. Do you feel or do you know of any research that's going to go into anterior knees and muscle activation around K-tape?
We've had a little look at K-tape a couple of times, and it's quite interesting. It's very definitely on the spectrum of feel better. And whereas a classic patella tape where you put a rigid zinc oxide in, you can sort of see how that might change your patella position, might, rotate a limb slightly, whereas the K-tape doesn't seem to work on that level and probably is purely about pain relief to allow you to do. And I suppose from my personal point of view with K-tape is that's the way I use it. I very much use it as I have a task I want the athlete to be able to do, whether that's a rehab exercise to get stronger or to be able to perform without irritating something, i.e. they do it pain-free. And by putting the tape on, we allow them to do it. So what they're doing is, if you like, developing the training miles to build up the biological tolerance in the tissue. And I suppose I have a split personality with tape, where I tend to use KT tape as a inaction tape, and then very much use the patella tape as an offload. So for the other 23 hours of the day, they would be patella taped, and then for the hour of rehab or whatever, they would be KT taped to allow them to do. And then they would go back to quite a rigid fix where we allow them to offload those structures or stretch those structures or whatever we perceive is happening.
Okay. And do you buy into the neuromuscular change that K-tape is said to influence?
There just doesn't seem to be the evidential base at all to support that. Every study which seems to come out doesn't seem to find it. Now there is a blackout with EMG, and there is a lot of error within EMG acquisition, which might be masking an effect which is quite small, but that's also probably the devil in the detail. I think very definitely with KT tape, that's the one as a clinician you go for your MBG, BBG. You very much put it on. Do they do what you want them to do? Ideally better, with less pain, and it achieves your goal, which is to get that biological mileage into the tissue so it can make those adaptive changes and get stronger. And I suppose that's that transition point between biological to mechanistic. KT probably is very much biological. It allows you to do something which then allows some adaptive changes.
So there you have it. Many thanks to Dr. Lee Herrington for his time and for sharing his thoughts and expertise with us all. But remember, part 2 is still to come, so unless you're already fed up with either or both of us, then be sure to subscribe on iTunes and follow our Twitter accounts to catch the business end of the interview. For a full summary of this interview, along with a copy of today's guest's latest presentation, which is Old Knees in Young Athletes, visit www.choosehealth.co.uk, and that's spelled CHEWSHEALTH, in keeping with my unusually Chinese sounding surname, and sign up for the Physio Matters Podcast newsletter. The newsletter will be distributed following each episode launch and will include exclusive presentations, full text articles, and links to the info and evidence discussed in each podcast. As a last-minute addition, our team have put together a timeline transcript of each episode, which should help you to find that golden 10 minutes that might refresh your memory in between patients. This is, of course, available via the show notes newsletter. Sign up for this for free at choosehealth.co.uk. Wrapping up then, you can follow us on Twitter at TPM Podcast and at choose_health. So thank you for listening, and be sure to subscribe for future episodes and stay informed via the show notes newsletter and on social media. You've been listening to the Physio Matters Podcast, discussing physio matters because physio matters. Bye for now.